Welcome to Deep Dive Ortho, the show dedicated to unpacking critical insights and cutting-edge developments for orthopedic professionals like you. Today, we're embarking on a comprehensive deep dive into a truly foundational aspect of orthopedic surgery, anatomic precision. We'll be exploring how a long-standing, respected body of knowledge continues to evolve and remain indispensable in today's increasingly complex surgical landscape. Our mission is to understand not just what makes a reference text valuable, but why a deep, nuanced understanding of surgical exposures remains paramount for enhancing patient safety and improving outcomes. Especially, I think, for experienced practitioners looking to refine their approach or perhaps adopt new techniques. Guiding us through this intricate subject is the insightful Prof. Mo Imam.
Thank you. It's always a pleasure to delve into topics that, well, truly get to the heart of what we do as orthopedic surgeons. Understanding the intricate pathways of the human body is far from merely academic. It is, quite frankly, the bedrock upon which all successful surgical intervention is built, particularly in orthopedics. Every incision we make, every fascial plane we navigate, or every structure we protect has significant implications, both for immediate operative success and for long-term patient recovery and function. The precision demanded in our field means that a comprehensive, almost intuitive grasp of surgical anatomy is the surgeon's most vital compass. It guides us through, often unforgiving terrains within the body.
Right. Let's begin by setting the stage then for what we're exploring today. A work that has influenced orthopedic surgical care worldwide for, well, nearly 4 decades now. We're talking about surgical exposures in orthopedics, the anatomic approach. This isn't just any textbook, is it? It carries the profound legacy of Dr. Stanley Hoppenfeld, whose ideas have been truly foundational. What, in your view, was the fundamental shift in thinking that Dr. Hoppenfeld introduced? And how does that transformative legacy continue in this current 6th edition, co-authored by Dr. Piet de Boer and Dr. Richard Buckley?
Indeed. Dr. Hoppenfeld's work isn't merely a cornerstone. It is, quite frankly, a monumental achievement in orthopedic education. It fundamentally reshaped how surgeons learn and apply anatomy. You see, before surgical exposures, anatomical texts often presented, static, two-dimensional cadaveric dissections, which, while accurate, didn't always translate directly to the dynamic three-dimensional reality of the operating theater. Dr. Hoppenfeld's brilliance lay in transforming this static anatomical knowledge into practical, step-by-step surgical pathways. He pioneered what he called a surgeon-centric view of anatomy.
Surgeon-centric.
Yes. So this wasn't just a description of what structures were present, but critically, how to safely and effectively navigate through them to reach the target pathology. He essentially demystified the often intimidating prospect of surgical exposure, making it accessible to surgeons at all levels, while at the same time stressing the critical importance of precision. The core insight he introduced was transforming static anatomical maps into dynamic, real-time surgical playbooks, if you like. It's about being able to pre-visualize the invisible, understanding of the intricate relationships of nerves, vessels, muscles, even before you make the incision, anticipating what you'll encounter at each layer.
Right, a real paradigm shift.
Exactly. It was a paradigm shift for surgical education, directly enhancing safety and improving patient outcomes by giving surgeons a reliable mental roadmap. And the continued collaboration with Dr. de Boer and Dr. Buckley in this 6th edition is crucial, precisely because it ensures that this core philosophy, this unique anatomic approach, remains intact and vibrant, while simultaneously integrating contemporary developments.
So it's not just being passed on, it's being actively maintained.
Precisely. This isn't a mere handover of a classic text. It's a profound act of intellectual stewardship. It ensures the book remains a living document, continually updated to serve the modern surgeon. This continuity is vital. It allows for the evolution of knowledge within a trusted and proven framework, incorporating new surgical techniques and updated understandings without compromising those foundational principles that made it indispensable in the first place. A reference text achieving such longevity and widespread adoption does so because it consistently delivers on its promise of enhancing surgical practice and patient safety. It demonstrates an innate understanding of what orthopedic surgeons truly need. Not just what is there, but how to safely and effectively get to it. And the meticulous process of being a fully revised 6th edition further underlines the commitment to maintaining its relevance and accuracy in a continually evolving surgical field, reflecting best practices and new understandings without compromising its foundations. It's really a testament to its enduring value and adaptability.
So it's not just about historical reverence then, but about dynamic relevance. It's about a foundational philosophy being applied to current challenges, ensuring that, the profound wisdom of the past seamlessly integrates with the innovations and demands of the present. That's a powerful legacy.
Absolutely.
Let's unpack this anatomic approach a bit further. The description highlights it as highly relevant and increasingly important as approaches become smaller. Now, this immediately brings to mind what seems like a critical paradox for our audience of mid-senior professionals. It might seem counterintuitive. Why does this emphasis on granular anatomic understanding become more important, not less, in the era of minimally invasive surgery or MA?
Right. This is precisely where the true genius and foresight of the anatomic approach really shine, particularly in modern orthopedics. You've hit on a critical point there.
Yeah.
At first glance, one might assume that if incisions are smaller and you're using advanced imaging, you might need to know less or direct anatomy. The reality, however, is precisely the opposite, and the stakes are significantly higher. As surgical techniques trend inexorably towards smaller incisions and less invasive methods, whether it's arthroscopy, percutaneous fixation, or endoscopically assisted procedures, the margin for error dramatically shrinks. You're no longer working through a large open field where you can broadly visualize all the structures. Instead, you're operating through a confined portal, often relying heavily on indirect methods like endoscopic imaging, fluoroscopic guidance, or, highly specific retractors and instruments.
So your direct view is much more limited.
Severely limited, yes. And tactile feedback can be attenuated or even distorted by instruments. In such scenarios, a comprehensive, almost intuitive understanding of the three-dimensional anatomy, including all potential variations, becomes non-negotiable. You must be able to mentally reconstruct the anatomy, predicting the precise location of critical neurovascular structures and vital soft tissue attachments, even if you can't see them directly. This book provides, as it says, a clear view of orthopedic anatomy from the surgeon's perspective. And this isn't just theoretical cadaveric anatomy, it's pragmatic, actionable knowledge designed for the theater.
Right, practical.
It's about visualizing the precise fascial planes that allow for safe dissection, anticipating the exact course of neurovascular bundles that absolutely must be protected, and understanding the origin and insertion points of muscle attachments that may need to be carefully elevated or split. This granular understanding allows a surgeon to perform what might appear to be a blind dissection with the confidence and precision of an open one, because their mental map of the operative field is so complete and accurate.
Can you give an example, maybe?
Sure. Consider a minimally invasive approach to the hip for, say, femoroacetabular impingement. Your incision might only be a few centimeters long. Now, without an encyclopedic knowledge of the femoral nerve and artery's precise relationship to the capsule and surrounding musculature, navigating that tight space safely while performing osteoplasty and reshaping bone would be extraordinarily risky. The ability to anticipate the exact location of these vital structures, even when they're just outside your immediate field of view, is what prevents iatrogenic injury. And the use of easy-to-follow descriptions and hundreds of superb, full-color illustrations is also paramount in this context. These visuals aren't merely pictures, they are detailed navigational charts. They serve as a vital preoperative mental rehearsal tool, allowing surgeons to mentally walk through each step of an approach, anticipate structures they will encounter and at what depth, and plan their dissection with exquisite precision.
Especially when you can't see everything directly.
Particularly critical then, yes. It's about making the abstract three-dimensional anatomy concrete for immediate surgical application, ensuring that every maneuver, however small, is deliberate, informed, and ultimately safe for the patient.
So the ultimate insight here is that MIS doesn't reduce the need for anatomical knowledge. It elevates it to an even higher plane, demanding an encyclopedic understanding of not just what should be there, but also what could be there in terms of anatomical variations. This sounds like it directly impacts decision-making and adaptability during a procedure, especially when you encounter the unexpected. It truly turns the surgeon's mind into, well, a living anatomical atlas.
That's a very good way to put it, yes.
Building on that idea of precision, the work extensively details the techniques and pitfalls of each surgical approach. It also provides a clear preview of anatomic landmarks and incisions, and crucially, highlights potential dangers of superficial and deep dissection. In your extensive experience, how does proactively addressing these pitfalls and dangers contribute to superior patient outcomes and significantly reduce complications? Especially for the complex or revision cases that our audience of experienced orthopedic professionals often handles.
Well, this aspect of the work is fundamentally about proactive risk mitigation and ensuring paramount patient safety in every procedure we undertake. Every surgical approach, no matter how routine it may seem or how many times a surgeon has performed it, carries inherent, unavoidable risks. These risks aren't just theoretical concepts. They relate directly to the proximity of critical neurovascular structures, the integrity of tendons and ligaments that must be protected, the optimal placement of fixation devices, and even the potential for iatrogenic injury to adjacent organs or structures. By explicitly detailing techniques and pitfalls, the work equips the surgeon with a comprehensive mental checklist of potential hazards and critical decision points before they even make the first incision.
So it's preemptive knowledge.
Exactly. Take, for example, a common scenario, approaching the lateral knee. Knowing the precise course of the common peroneal nerve as it winds around the fibular head is absolutely vital. This book doesn't just show you the nerve, it specifically highlights the danger of inadvertent traction or direct injury during retraction or deep dissection in that specific area. Or, think about the radial nerve in the spiral groove of the humerus during a humeral shaft exposure. The text guides you on how to identify it, protect it, and potentially mobilize this nerve to prevent a devastating wrist drop. This level of detail allows for careful, deliberate retraction or dedicated protection throughout the procedure. It transforms potential disaster zones into navigable pathways. Furthermore, understanding the implications of a particular incision on subsequent soft tissue healing, scar formation, or even long-term lymphatic drainage can influence not just aesthetic outcomes, but also functional recovery and patient comfort. The work doesn't just show you how to get there, it tells you what to avoid along the way and, crucially, why those structures are vulnerable. It's about understanding the red flags that appear during dissection.
And for more experienced surgeons.
For mid-senior professionals, this foresight is invaluable on multiple levels. It's not just about refining their own technique, but it's critically important for effectively teaching and mentoring junior colleagues, fostering a deeply ingrained culture of safety within the surgical team, and particularly, as you mentioned, for approaching cases that present atypical anatomy. We often encounter congenital variations, or more commonly, patients with previous surgical scarring from prior operations.
Yes, revision surgery must be a prime example.
Absolutely. Revision surgery often means operating in a field where normal tissue planes are obliterated, scar tissue obscures landmarks, and critical structures may be displaced from their expected anatomical positions. The clear preview of anatomic landmarks acts as a reliable navigational chart even in such a distorted landscape, while the potential dangers serve as crucial, detailed warning signs. It's about proactive avoidance of iatrogenic injury caused by the medical intervention itself, which translates directly to fewer complications, reduced need for reoperation, faster recovery times, and ultimately significantly better patient satisfaction and functional outcomes. This systematic detailing also fosters a culture of critical self-assessment and continuous learning within the surgical team, consistently elevating the standard of care for every single patient.
That truly highlights how this text functions, like having a highly experienced co-pilot who has not only mapped out all the potential turbulence zones, but has also equipped you with the precise knowledge to navigate them safely, complete with contingency plans. That foresight and detailed preemptive knowledge are utterly priceless in the operating theater, especially when a patient's long-term function hangs in the balance.
Precisely. It's invaluable.
Now, let's talk about the specific updates that make this 6th edition so compelling for today's orthopedic surgeon. The description mentions a remarkable 21 new surgical approaches. This isn't just a minor revision. It signifies a substantial expansion of knowledge, reflecting the dynamic nature of our field. Can you walk us through some of the particularly significant additions and what they mean for modern orthopedic practice? For instance, the fixation of rib fractures, or perhaps the suprapatellar approach for tibial nail insertion.
Absolutely. The inclusion of 21 new approaches demonstrates an acute responsiveness to evolving surgical needs, advancements in orthopedic trauma, and the continuous refinement of existing techniques. These additions reflect, I think, a profound understanding of the current clinical challenges faced by orthopedic surgeons, often in areas that are becoming increasingly interdisciplinary.
Like the rib fractures you mentioned.
Yes, consider the fixation of rib fractures.
Yeah.
While traditionally seen more perhaps as a thoracic surgery domain, orthopedic surgeons, particularly in high-volume trauma centers, are increasingly involved in complex chest wall stabilization for severe injuries, especially in polytrauma patients. These fractures, if unstable or multiple, can lead to significant pain, paradoxical chest wall movement, flail chest pulmonary compromise, and prolonged hospital stays with increased morbidity and mortality. Providing a detailed surgical approach here reflects the increasingly multidisciplinary nature of complex trauma care. It equips the orthopedic surgeon with necessary insights into an emerging, yet critical, area of responsibility.
So it acknowledges that expanding role.
Exactly. It acknowledges the orthopedic surgeon's expanding role in managing the entirety of the musculoskeletal injury burden, even extending to the axial skeleton and chest wall. The detailed anatomical guidance ensures that when we undertake this, we do so with the utmost precision, avoiding damage to underlying lung tissue or intercostal neurovascular bundles.
And the suprapatellar approach for the tibia.
The suprapatellar approach for tibial nail insertion is another excellent example of a highly relevant addition. It addresses a persistent clinical challenge. This technique offers significant advantages in certain fracture patterns, particularly proximal tibial fractures, which can be notoriously difficult to reduce and nail adequately with traditional infrapatellar approaches. You see, the traditional approach often necessitates extreme knee hyperflexion, which can be challenging or even impossible in obese patients, those with multiligamentous knee injuries or concomitant hip or pelvis injuries.
Right, I can see that.
The suprapatellar entry point, by contrast, allows for a more straight-line trajectory and better alignment of the intramedullary nail with the long axis of the tibia. This not only reduces the need for difficult knee positioning, but can also significantly reduce fluoroscopy time due to improved ease of entry and alignment. And crucially, it potentially mitigates anterior knee pain, which is a common, persistent, and often debilitating complication associated with infrapatellar approaches, directly enhancing patient comfort and long-term function.
So better outcomes, potentially less pain?
Precisely. Its inclusion underscores the drive for optimizing surgical efficiency, achieving superior biomechanical alignment, and enhancing patient comfort and long-term functional recovery. It really is a game changer for selected proximal tibia fractures.
What about minimally invasive approaches?
Yes, we also see a minimally invasive approach to the clavicle. This perfectly reflects the broader trend in orthopedics to reduce tissue disruption while achieving stable fixation. For a superficial bone like the clavicle, where cosmesis is often a significant patient concern due to its visible location and the soft tissue envelope is relatively thin, a minimally invasive technique can dramatically reduce scar burden, potentially lower rates of infection and wound complications, and accelerate soft tissue healing. This balance between achieving robust, stable fixation and minimizing tissue invasiveness is a constant pursuit in orthopedic surgery, and this detailed approach provides the anatomical roadmap to achieve it safely.
And there were others mentioned, for the humerus and femur.
Yes. Furthermore, the addition of the posterior triceps on approach to the distal humerus and 3 new approaches to the distal femur signifies a deepening of options for complex long bone fractures or osteotomies. These additions provide surgeons with more nuanced and tailored pathways depending on the specific fracture morphology, for example, highly comminuted fractures versus simple spiral fractures, the presence of comminution, the need for direct visualization of articular surfaces, and patient specifics like body habitus or pre-existing conditions.
So more tools in the toolbox depending on the exact problem.
Exactly. Different distal femur approaches might be optimal for supracondylar fractures versus paraprosthetic fractures around a knee replacement, or for complex osteotomies and deformity correction. Having multiple, precisely detailed options allows for a truly patient-specific and injury-specific surgical plan, optimizing exposure while minimizing morbidity.
And the focus on elbow and foot ankle.
Finally, yes, the expanded content on the anteromedial approach to the elbow and new approaches to the talus, cuboid, navicular, and Lisfranc's joint highlight a crucial and comprehensive focus on the intricate anatomy of the elbow and foot ankle. These are areas with some of the most complex biomechanics and, frankly, unforgiving neurovascular arrangements in the entire human body. The elbow, for instance, with its dense neurovascular, bundles the ulnar, median, and radial nerves in the close proximity of vital structures, demands meticulous, almost microscopic dissection to avoid iatrogenic nerve injury or vascular compromise. The foot and ankle, on the other hand, are characterized by numerous small bones, multiple interconnected joints, and critical weight-bearing functions, making precise approaches paramount for successful outcomes in conditions ranging from traumatic injuries to degenerative pathologies and complex deformities. The Lisfranc's joint, for instance, which is critical for midfoot stability, often involves subtle injuries that can have devastating long-term consequences if not diagnosed and treated meticulously. Detailed approaches here are essential for accurate reduction and stable fixation, preventing chronic pain, debilitating arthritis, and long-term functional disability. These additions underline a commitment to addressing the full spectrum of orthopedic challenges with the utmost anatomical precision, providing the blueprints for successful surgery in these intricate regions.
That's truly fascinating. A clear reflection of current orthopedic challenges and the ongoing pursuit of better techniques that directly translate into improved patient quality of life. Beyond these entirely new approaches, the work also mentions fully revised content throughout, including changes to the trochanteric osteotomy required to perform surgical hip dislocation and updated content on external fixation. Can you speak to the significance of these revisions for our experienced audience? Why do these refinements matter so much?
Well, these revisions are equally, if not more, significant than the new approaches. They indicate a refinement of established techniques based on new evidence, improved understanding of biomechanics, and long-term clinical outcomes. They demonstrate that even well-known procedures are constantly being scrutinized and optimized for patient benefit. And this is critical for experienced surgeons who are always looking to perfect their craft.
Okay, take the trochanteric osteotomy, for example.
Right, the trochanteric osteotomy. It's a critical step for procedures like surgical hip dislocation, often performed for conditions such as FAI, a vascular necrosis of the femoral head, or other complex hip pathologies needing direct visualization of the entire femoral head and acetabulum. The revisions here suggest updated best practices for safely performing this osteotomy, which involves cutting and reattaching a part of the greater trochanter. The precision of this osteotomy and its subsequent reattachment is absolutely paramount for several reasons. It's critical for preserving the vascularity of the femoral head. A misstep here can lead to a vascular necrosis, a devastating complication, and ensuring robust bone healing for optimal postoperative function is key.
And poor reattachment causes issues too.
Exactly. Incorrect reattachment can lead to painful non-union or trochanteric bursitis. These changes reflect an ongoing commitment to continually improving patient outcomes in complex joint preservation surgeries, where the stakes are incredibly high for young, active patients whose future mobility depends on it. It's about optimizing the surgical approach to minimize morbidity and maximize the chances of excellent long-term results, building on decades of cumulative experience.
And the external fixation updates.
Updated content on external fixation is also very timely and relevant for our audience. External fixators remain invaluable tools across various orthopedic subspecialties, particularly in complex trauma for temporary stabilization of open fractures or unstable pelvic injuries, in limb reconstruction for deformity correction or bone transport, and for managing infected non-unions where internal fixation might be contraindicated. The updates would likely cover advancements in frame design, improvements in materials, more sophisticated pin configurations, increased modularity allowing for greater versatility, as well as refined principles of pin site care to reduce infection rates and a deeper evidence-based understanding of the biomechanical principles guiding their application for optimal stability in bone healing.
So it's about better tech and better understanding of how to use it.
Yes, it reflects a deeper, evidence-based understanding of tissue biology, infection control, and improved clinical results gleaned from decades of experience with these devices. For the modern orthopedic surgeon, these revisions mean access to the most current and effective strategies for employing external fixation, ensuring better patient outcomes in even the most challenging scenarios, like complex open fractures or highly contaminated wounds. Ultimately, these revisions ensure that the work remains current and reflects the most advanced understanding of surgical anatomy and technique. Crucial for professionals who are constantly striving for optimal results in navigating complex clinical scenarios where precision and up-to-date knowledge are non-negotiable. They show that mastery is an iterative process.
That's a truly comprehensive approach to keeping a foundational text current. It's not just about adding new chapters, but continually refining the existing knowledge base, always pushing the boundaries of what's possible for patient benefit.
Absolutely.
Beyond the detailed content, the work itself embraces modern learning methods, moving far beyond the static page. It offers access to numerous high-quality procedural videos from every relevant angle, including a split screen with diagrams. Now, this immediately signals a powerful tool, especially for visual learners and for reinforcing surgical steps. How do these digital enhancements, especially the videos, transform the learning and practical application for a busy orthopedic surgeon? What's the practical impact of having this kind of dynamic resource at one's fingertips?
Oh, this is an extremely valuable addition, one that perfectly aligns with contemporary educational paradigms and, crucially, the practical demands of a busy orthopedic surgeon's life. Static images, however superb and meticulously drawn, can only convey so much information about the dynamic, three-dimensional reality of a surgical procedure. Dynamic, high-quality procedural videos, on the other hand, provide a multi-dimensional understanding that's simply impossible to achieve otherwise. They literally bring the anatomical descriptions to life, showing you the anatomy in motion as it would appear during a dissection.
And the different angles are important.
The phrase, Every relevant angle is absolutely key here, yes. It allows a surgeon to view the dissection and exposure, not just from the typical perspective they would have standing at the operating table, but also from different anatomical vantage points. For instance, you might see an overview of the regional anatomy, followed by a close-up of a critical dissection plane from an overhead view, and then perhaps an angled view that clarifies the precise relationship between a nerve and a specific muscle belly as you retract tissues. This comprehensive visual experience aids significantly in comprehension of spatial relationships paramount in orthopedics, where depth and precise positioning are everything.
And the split screen with diagrams, how does that help?
The split screen with diagrams further enhances this by concurrently showing the live dissection alongside a meticulously labeled schematic. This isn't just a convenience. It's a powerful pedagogical tool that leverages cognitive principles of visual learning. It instantly reinforces anatomical correlation, allowing the viewer to identify and name critical structures as they are encountered in real time within a living tissue context. This simultaneous visual reinforcement helps cement knowledge and highlight the precise location of structures that need protection or careful handling. Imagine having a complex revision total hip arthroplasty scheduled, being able to watch a video demonstrating the precise plane of dissection and emestification of the sciatic nerve in previously scarred tissue, with a diagram highlighting its course. Well, that's an incredibly impactful way to prepare.
Almost like being there.
It allows for a mental rehearsal that is almost as good as doing it in the cadaver lab, but infinitely more accessible. For busy professionals, this translates to incredibly efficient, targeted learning. You no longer have to spend hours poring over static images trying to infer three-dimensional relationships from two-dimensional representations. You can review a specific surgical step or a less common approach rapidly before a case, consolidating knowledge and boosting confidence just hours or even minutes before you scrub in. This is about real-time, on-demand learning.
Bridging theory and practice effectively.
Exactly. It bridges the critical gap between theoretical knowledge and practical application, accelerating the learning curve for new techniques and significantly refining existing skills. Furthermore, the ability to easily convert the text to an audiobook format speaks directly to the need for flexible learning options in demanding professional lives, allowing for continuous education even during commutes or other non-traditional learning times. This integration of multimedia and flexible formats truly makes it a modern reference for the modern surgeon, allowing for true mastery in an age of constant innovation.
So it really moves beyond a passive read to an interactive, almost immersive pre-surgical experience. This speaks directly to how knowledge can be integrated into clinical practice in a truly impactful way, allowing for rapid assimilation and reinforcement, which is crucial for busy professionals. It's like having a master surgeon guiding your hand, even when they're not physically in the room.
That's a very apt description, yes.
Oh? Well, this has been an incredibly insightful deep dive into what makes a true cornerstone of orthopedic literature. It's clear that while the fundamental principles of anatomy remain constant, the application and understanding of surgical exposures continue to evolve, demanding that even experienced professionals stay at the forefront of this foundational knowledge. We've discussed how the profound legacy of Dr. Stanley Hoppenfeld endures, how precise anatomic understanding is more critical than ever in the era of minimally invasive surgery, the vital role of identifying pitfalls for paramount patient safety, and the exciting new approaches and revisions that reflect current best practices in the field. And the inclusion of high-quality digital resources truly rounds out this comprehensive offering, making it an indispensable tool for every surgeon.
Indeed. What we've explored today reinforces that surgical excellence in orthopedics is not just about technical skill, as important as that is. It is fundamentally about a profound and continually updated understanding of the human form. This anatomical mastery ensures not only the efficacy of our procedures, but also the paramount safety and well-being of our patients, leading to better outcomes and faster recoveries. It underscores that even the most seasoned surgeon benefits immensely from consistently re-engaging with the fundamental anatomic principles that underpin their craft. True mastery is a lifelong pursuit, and the constant refinement of one's anatomical compass is central to that journey, ensuring we always operate with precision, purpose, and the patient's best interests at heart.
That's a powerful thought to leave our listeners with the ongoing journey of mastery through foundational knowledge, constantly refined. We hope you found this deep dive as illuminating and practically valuable as we did. If you appreciate the detailed insights we bring to your practice, please take a moment to rate and share Deep Dive Ortho with your colleagues. Thank you for your expert guidance today.
My pleasure.
And thank you, our listener, for joining us on Deep Dive Ortho. Until next time, keep exploring, keep learning,